Hello, everyone, and thank you so much for joining us for this educational seminar, Skin Manifestations of Systemic Diseases. It's 7 o'clock, so we're going to get started. My name is Kim Montanarello from VisualDx, and we have been thrilled with the success of our webinar series this year and so happy that you're able to join us for this very important topic. First, I'd like to do a little bit of housekeeping. You will all be on mute for this presentation, but we do really welcome your questions. You'll see in the Q&A box. Please use that and we'll try to get as many as we can. Also, following our presentation, we'll be testing your knowledge with a fun interactive quiz. It's called Kahoot. I would recommend you download the app if you haven't done so already. It's free in Google Play and the Apple Store. Or you can do it right on the desktop. The link will be coming up after the presentation. We also know that the winner will receive a $100 Amazon gift card. Our presenter today is Dr. Azeen Sadeghian. Dr. Sadeghian is a board-certified dermatologist in Baton Rouge, Louisiana. She earned her medical degree at Louisiana State University School of Medicine in New Orleans, and then completed a clinical research fellowship and dermatology residency at Tulane Health Sciences Center in New Orleans. Dr. Sadeghian's expertise is in diagnosing and treating a wide range of conditions affecting the hair, skin, and nails. She is passionate about atopic dermatitis and digital resources, including VisualDx. Professionally, she is active in the Louisiana State Medical Society, sits on the advisory board for the American Academy of Dermatology, and serves as the editorial committee chair for the Women's Dermatologic Society. She is also currently a voluntary adjunct assistant professor at Tulane Health Sciences Center. So, without further ado, Azeen, take it away.
Thank you, Kim, for that wonderful introduction. It is nice to see y'all today, and I hope you guys are having a great evening. Today, we're going to be talking about cutaneous manifestation of systemic diseases. This is such a great topic to cover, and honestly, there's so many systemic diseases that have skin manifestations. We won't be able to cover them all tonight, but I do want to kind of touch on the high-yield ones. So what do we want to do tonight? We want to learn some of the skin findings in important systemic diseases. And also notice some different findings in different skin colors, or what we call the Fitzpatrick skin types. This is going to be a cognitively interactive format. We're going to see an image first, and you're going to have no history. You're just going to see a rash. And then I want you to think of your description, begin a differential, and then we're going to learn the diagnosis and look at some more images. We're going to go really quickly, so buckle up, pay attention. And then if you guys have questions, definitely type them into the chat box, and we'll get to them at the end of the presentation. So here is an image, and I would describe this as an erythematous to biolaceous edematous plaques on the distal fingertips, and you see kind of a biolaceous retiform modeling of the dorsal hands. You can kind of see the rash. I'm just going to describe it for you. This is COVID, okay? Why do we need to know about this? Well, it's very pertinent to what's going on. We see a lot of people just present with kind of atypical findings, and skin findings, fortunately, are not the most common findings, but they do occur. So we know about our COVID toes, and we know about actually the fingers can be affected as well. So widespread varying clinical presentations, and various organ systems are affected. I mean, you have conjunctivitis that can occur, you have ARDS that it can occur, cardiovascular findings, GI, neuro, almost a Kawasaki's like presentation, all these different presentations that are coming out. So some common symptoms we already know about. I'm not going to spend a lot of time on this. You know about the fever, cough, dyspnea, fatigue, malaise, things of that nature. And you know also about the lab findings. You can have lymphopenia, neutrophilia. You can have increased liver enzymes, ferritin, CRP, LDH, and these findings may be associated with a greater illness severity. On pulmonary imaging, you might find ground glass opacities on imaging. I encourage you to look at the VisualDx images. They have a wonderful array of images that have been sent internationally, and including chest x-rays and CT scans. So what are the cutaneous findings associated with COVID? Pernio-like lesions, which is something that we just saw in that first image and the second image, occur on acral surfaces. You know, you think of kind of like the areas that get perniosis, or the areas that get kind of like your cold exposure and can get damaged by that. So your acral surfaces, fingertips and toes. You can get erythema, edema, vesiculation, and purpura. And the lesions can be painful, itchy, or asymptomatic. The feet occur more than the hands, hence the term COVID toes. Younger individuals tend to get this later in the disease course, and it's usually associated with a milder illness. There is a vesicular eruption. Think of kind of like blisters or something like chickenpox, but the difference is this occurs all at the same stage versus chickenpox kind of emerges in different stages. These can coalesce and become hemorrhagic. Middle-aged patients will tend to get this, and this tends to have a more moderate disease severity, and itch is common. Other findings include an urticarial eruption, kind of like hives, or a macular or papulosquamous eruption, which is very nonspecific, and then livido or retiform purpura. Transient livido has been seen in milder illnesses, and retiform purpura can be complicated by skin necrosis or the skin dying, and can be seen in individuals with severe disease. Okay, so this is kind of your classic morbilliform eruption, and I think that should give you the clue right there. So don't think too long about it. This is measles, or why do we need to know about this? And the reason why I put this in here is actually, I don't know if you guys have realized this, but some immunization programs have been disrupted due to COVID, especially internationally, such as like polio. And, you know, we actually had a measles outbreak recently in 2019. We had a peak in measles cases. So I don't think people should sweep this under the rug just because we have another, you know, more important pandemic going on. So you can see that with measles, you get your cough, coryza, and conjunctivitis. Coryza is a mucus discharge of the mucous membranes of the nose. So, and you also get oral complex spots, that's pathognomonic. You probably wouldn't see that, though, by the time the patient presented. And so here are some classic images of measles. I hope you guys never see it, but I want you to be prepared if you do. And transmission is respiratory for this, and it begins nasopharyngeal and or conjunctival, and it spreads to the lymph nodes and blood and causes viremia, and then you kind of develop your rash after that. And so the rash begins kind of from the frontal hairline and heads down. There's some other images. You can kind of see these erythematous papules on the cheeks, and I really want to emphasize this. And then you see your morbilliform eruption or rash here. Okay, so as we can see here, we have an ulcer, and we also see a callus, and we also see kind of some poor blood flow to the toes possibly, and we see right here this kind of violaceous purpuric toe and some pallor around it. So this is a diabetic foot ulcer or mouth perforans. So we're going to talk about skin findings of diabetes mellitus. I'm not going to talk about the disease of diabetes because I think we're all familiar with that, but more focusing on the skin findings. So you can see here that we have acanthosis nigricans, this thickened, velvety, hyperpigmented plaque. Likes to occur in kind of creased areas around the neck, under the arms. You know, it's associated with insulin resistance and metabolic syndrome, but it can be associated with other diseases. If you see somebody who is not obese, or they don't have any stigmata of diabetes and their labs are normal, but they have a new onset acanthosis nigricans, and especially if it's affecting kind of other areas like the hands or around the mouth, that's kind of unusual. You want to make sure they don't actually have gastric carcinoma or stomach cancer. Okay, here you can see this large bulla, and this is bullous diabeticorum. And the reason why this happens is because we know the microvasculature is disrupted in diabetes. And this also plays a role into diabetic foot ulcerations as well. And then lastly, necrobiosis lipoidica diabeticorum, which is these yellow, they can be atrophic plaques, and it likes the anterior lower legs. And it tends to be painless, atrophic. You can sometimes see telangiectasias, these little broken blood vessels, and they tend to be either, you know, they can be unilateral or bilateral, but it's very common to see it on the pretibial surface. Here's a close-up. This is showing acanthosis nigricans in a lighter skin type. I find that it's a little bit more obvious in darker skin types, but in lighter skin types, it can be missed. And this is someone who probably has a middle Fitzpatrick type, you know, around 3. So this isn't as light as it can go. but you want to be able to recognize it even in your Fitzpatrick 1s, 2s, which are your fair skin types. You can also see these skin tags, which can be associated with either insulin resistance or acanthosis nigricans. Okay, this one's going to be a little hard to describe, so I'm going to just kind of describe it for you. You can see something's going on here. This is what we call retiform ulcerations and eschars. Eschars are scabs, if you can think of it that way. Retiform kind of means like a broken net, meaning the distribution kind of looks like that. You see a violaceous mottled background. You kind of see how you can see where the blood vessels are in this area in that large ulceration. And so you know that something's happening on a vascular level. This is calciphylaxis. So calciphylaxis is seen in chronic renal failure. You can see it in your hemodialysis patients, and you can also see in secondary hyperparathyroidism. And so non-traditional causes are less common. It likes to happen in fatty areas. Think of the thighs, the buttocks, the abdomen. Early, it is quite painful, very, very painful. In fact, that's going to be a very notable feature. And you get those violaceous retiform patches and plaques. Later, you get the necrosis, the ulceration, the eschars, and even possibly gangrene. And it has a high mortality because you have to think about it. If the renal failure is affecting the body and causing the vasculature to do this, you're not in a good situation. And so also you can get sepsis from these large wounds, and it's hard for the skin and tissue to repair itself because the vasculature is disrupted. And so for the non-traditional causes, calciphylaxis, you can see those in other diseases such as liver disease, warfarin use, if you use calcium-based phosphate binders, solid organ malignancies, and other diseases. But I think the main thing you need to know is the association with chronic renal failure. Here's some more pictures. You can see these are kind of the earlier stages of it before the skin breaks down. And you see here that once the skin breaks down, you form the eschar, or that thick scab. Kind of what can happen after this, you can definitely get ulceration. So the gold standard for diagnosing this is a tissue biopsy, but it can be subject to sampling error. And also sometimes, unfortunately, a biopsy can trigger an ulcer formation, and you have to do kind of a deeper biopsy. So, some tips: you're definitely going to need to get wound care involved, and you're likely going to need help with pain management. You can consult surgery for wound debridement or a parathyroidectomy. You definitely need a multidisciplinary approach. Medicine is going to be really helpful: nephrology, critical care, dermatology, surgery, and a pain specialist. You want to minimize or eliminate exacerbating factors. If there's iron, calcium, vitamin D, warfarin, that's what you want to discontinue. Maximize management of the comorbidities. Make sure their blood pressure, cholesterol is under control, sugar levels, things of that nature, and make sure peripheral vascular disease is managed as well. Definitely don't want to be smoking with this. Smoking clamps down blood vessels, and you want to maximize nutritional support. And normalization of the serum calcium phosphate levels via non-calcium based phosphate binders are helpful. And then you want to normalize the parathyroid levels. And so treatment is IV sodium thiosulfate. Okay, as you can see here, we have these deep-seated erythematous, almost violaceous nodules. I'm assuming they're tender. They look like they would be tender, and they're on the anterior lower legs. This is Erythema Nodosum. Erythema nodosum is the most common inflammatory panniculitis. It's symmetrical, bilateral, and it likes the pretibial region. Triggers can include infection, pregnancy, medications, connective tissue disease, or malignancy. Out of the infections, streptococcal infections are the most common factor in children. And then you kind of see more immune reaction type triggers in adults due to either sarcoid, inflammatory bowel disease, or even medications. When you think of medications, you think of your contraceptive pills. Other infectious causes include Shigella, Yersinia, Histococcoides, HIV, and TB. Autoinflammatory causes, you think of your autoimmune diseases, such as we already mentioned sarcoid, inflammatory bowel disease, Sjogren's, reactive arthritis, Behçet's, and Sweets. Clues are that these are tender, smooth as well. You're not going to see any scale, and these are deep-seated. Arthralgias are common, meaning patients might complain of joint aches. And another thing to mention is that these do not ulcerate. This is going to differentiate it from other forms of paniculitis, or paniculitis is a category of inflammation, inflammatory disease in the fat cells. So this one won't ulcerate, but other forms of paniculitis can ulcerate. Here are some more images, kind of showing you different skin types. In a bare skin patient who's a Fitzpatrick, 1, 2, it's going to be a little bit more obvious. You're going to see that erythema. It's not going to be as subtle, but when you start to look at darker skin types, say this is a Fitzpatrick type 5, you see that the erythema is more subtle, and it almost looks more violaceous as a result, due to the reflective or refractive nature of melanin in the skin. And you can see here, this is someone who's probably more of a Fitzpatrick type, closer to a 3, and you can even see that the erythema is a little less notable in that situation. Okay, Loughran syndrome is a benign variant of sarcoid, but the reason why I bring it up here is because you have erythema nodosum and you have bilateral enlargement of the hilar lymph nodes, and you can get arthritis, uveitis, and fever. This is kind of a testable diagnosis, and I think that's why a lot of us learn about it. This occurs more commonly in females, especially during pregnancy, and your kind of characteristic patient group is going to be somebody of Northern European descent, and fortunately this tends to resolve within 2 years. And we're also going to touch base on that later as well. Okay, this one's a little easy. You get 2 pictures, and I think you should be able to tell what I'm getting at here, because you see a cause and an effect. And so you can see here, you have this bullseye appearance, and it's due to a tick-borne disease. You might not see this necessarily in Louisiana, but you're definitely going to see it if you live in some of the northern states. We do have ticks all over the country, but certain ticks are associated with certain diseases. And yeah, so this is going to be Lyme disease. So that rash I showed you is called erythema migrans, and it begins in the early phases, shortly after the tick bite. It usually occurs at the site of the tick bite in most cases. You may or may not have other symptoms going on at that time, and you tend to get false negative testing. Early disseminated will occur weeks to months following a tick bite, and you can get more lesions. You can get multiple of those bullseye type lesions, or even a widespread rash. You can start to develop neurologic features. You may even get Bell's palsy. That's the most common cranial nerve neuropathy associated with Lyme disease. And then some people start to get cardiac manifestations, such as an AV block or myocarditis. At this point, your serologic testing is usually positive. Late months or few years after the tick bite, some people, it just doesn't go diagnosed, or they maybe never had a rash to trigger them to go to the doctor. You can start to see chronic arthritis, typically in the knees, and then you can even get mild encephalopathy with subtle cognitive deficits, and then axonal polyneuropathies. Serologic testing is virtually always positive. So here's some more images that I want to show. This is not like a scaly rash that you think of. This tends to be erythematous smooth, and it likes to form these annular targetoid type lesions. Targetoid meaning like you think of a bullseye target. And this one's so classic, right? This one's a little more subtle, but you see that these are erythematous patches, and you have to just kind of keep this in the back of your head. So we're going to go through these symptoms to try to reinforce this. In your early localized stage, you may have a low-grade fever, you'll have your blanching bullseye annular patch, and then you may have malaise or myalgias. Early disseminated, you're going to start to get more symptoms. You may have more of a rash, joint swelling, photophobia, facial palsy, and a headache. Late chronic, you're going to get your joint pains, paresthesias, and neuropathy. Okay, and I do want to give you a caution. We're going to show a genital image next. Okay, so this one's kind of hard. Anytime you have genital lesions, it's really hard because you automatically think of different things. And so notice the location here is around the coronal sulcus. You have these kind of round, eroded areas, okay? Not deep ulcers. These are very superficial. And here's a clue. What if this guy has urethritis? This is reactive arthritis, okay? So any acute presentation of an asymmetric lower extremity painful arthritis plus that kind of genital finding, it should make you suspicious of this. So reactive arthritis represents a spectrum. We know that there's your classic triad of arthritis, urethritis. In women, it would be cervicitis and conjunctivitis. But reactive arthritis encompasses a category of spondyloarthropathies. You're going to have sterile joint fluid, and you get acute painful oligoarthritis, meaning less than 5 joints, stiffness, pain in the lower back. You can get enthesitis. Enthesitis is affecting kind of your tendon insertion points. You can get dactylitis, swollen digits, and that's common. Chronic arthritis may persist in a few people, and that's usually with association with the HLA-B27 phenotype, which is usually seen in a lot of, kind of your tests, your board exams. They'll ask you about that association. Conjunctivitis is bilateral and mucopurulent. Here we can see kind of the palms and soles involvement. You can almost get, it almost looks like palmoplantar psoriasis. This is a rash called keratoderma blennoragicum, and it's characteristic of reactive arthritis. Reactive arthritis is usually triggered from infection. It can be GI or GU. You can see the causes here. It occurs in kind of your younger adult population, 20 to 40. And for GI related infections, it tends to be male and females are the same. But if you have a chlamydia induced reactive arthritis, it tends to be more in males. For most patients, reactive arthritis is self-limited, and patients tend to recover completely within 2 to 6 months. And you do want to see why did they get the reactive arthritis and do a workup for that. Patients can sometimes have other systemic features such as fever, weight loss, fatigue, and rarely they can have heart findings as well. Okay, what is this picture showing? That's another presentation of the keratoderma blennoragicum. So if it looks like palmoplantar psoriasis, but it's not, that's keratoderma blennoragicum, especially if you have those other findings we talked about. So the skin findings to focus on it is, the keratoderma blennoragicum, but you can also get the balanitis cercinata or cercinate vulvitis, which is that first genital image I showed you. And then you can also get oral ulcers and geographic tongue, and then paronychia. So here's some images of geographic tongue. You can see here the paronychia, the cercinate balanitis, and you can see kind of this classic rash. This is, when you think of keratoderma blennoragicum, you think of the bottom of the foot, but really you can get those psoriasis-like lesions elsewhere on the top of the foot, top of the hands as well, or even on the body. So here's some more images. I want to focus on this one in a dark skin type. You can see how the presentations can vary, okay? And then you see more paronychia involvement, and then more of the skin findings here. I do want to mention, if you think it's eruptive psoriasis, the difference is eruptive psoriasis kind of looks like guttate or raindrops, and it's usually associated with strep. So it looks different. So reactive psoriasis is a different situation and it's not called reactive psoriasis, it's called eruptive psoriasis, but that's just different than reactive arthritis. Okay, here, this is definitely, I'm going to tell you this is going to be an itchy rash right now. And you see that this patient kind of has some areas where it looks like it's clearing, some areas where it looks more obvious. You see urticarial plaques and wheals. Right here, you can see that it's quite urticarial. Let's say if I told you this patient got IV contrast without pretreatment, urticaria. So urticaria or hives, there's different categories of it. Acute is no onset or recurring less than 6 weeks. Chronic is recurring for more than 6 weeks. There's allergic and non-allergic causes. For acute, for your less than 6 weeks, about half of the causes won't be identified. 40% of cases are associated with upper respiratory infections. Some are associated with medications, and 1% with foods. Acute urticarias tends to be seen in children. Inciting drugs can also include aspirin, NSAIDs, morphine, codeine, penicillin, various medications. And you have to be careful because acute urticaria can also present an anaphylaxis. Although it's more commonly seen in children, you do see it in adults a lot, so be aware of it. It's quite alarming whenever you see like a whole body urticarial eruption. Chronic urticaria, think longer than 6 weeks, usually occurs in women and middle-aged individuals. It can be due to autoimmune causes, physical stimuli, or idiopathic. When it's idiopathic, it's chronic idiopathic urticaria. NSAIDs, food, alcohol, stress, and infections can sometimes aggravate it, but it's rarely the cause. Non-physical chronic urticaria may be associated with other autoimmune conditions. And so a lot of times you just kind of want to make sure they don't have other autoimmune things going on, like thyroid problems, vitiligo, type 1 diabetes, rheumatoid arthritis, or pernicious anemia. This requires an extensive workup, which is beyond the scope of this talk, but there is an antibody that's sometimes associated with this, which is the Fc epsilon receptor 1 antibody. The disease can resolve within 12 months in about half of the patients, but some patients, it can persist for many, many years. This is a very difficult disease for patients to have because you're breaking out in hives all the time and you really don't always have like a way to control it easily. And it's very itchy and it can disrupt, your quality of life. So here, hives can look like a lot of different things. So I would definitely encourage you to look at an atlas with different pictures of urticaria. VisualDx has a wide array of different images because urticaria can look like a lot of different things. So you can see here that this looks different than that first image I showed you, and so does this. This is like, wow, a huge red edematous plaque, or it may even be a smooth patch. You would have to feel it to tell the difference. And this is a little bit more subtle. It almost looks annular. Now, I do want to caution you in darker skin types, you might not see that obvious erythema, but you should see some swelling in the skin, but you might have very subtle findings. And here you see this rim of pallor in the wheals, okay? You can tell for both of these are very indurated. They're swelling in the skin. Okay, so I would describe this as flesh color, deep-seated papules, smooth papules and nodules on the nasal alar rim. This is sarcoidosis. Sarcoid is a granulomatous inflammatory disorder. It is one of the great mimickers. It can look like anything and it can affect any organ system. So it's always good to, if you're stumped, put sarcoid in your differential, right? That's kind of the trick we all learned in school. It's bimodal in age distribution, meaning it can affect what ages 25 to 35 or 45 to 65. It's most commonly observed in Black women in the 4th decade of life. You can get fever, night sweats, and weight loss, and it can affect any organ system like we talked about. Now, some lesions of sarcoid can look different. Some can be atrophic, some can be thickened. So we'll show you some different images. This is a very unique image right here. With sarcoid, you do want to be cautious about pulmonary involvement. 90% of cases will have pulmonary involvement with hilar lymphadenopathy. You can get honeycombing and end-stage lung disease. You do have some patients with hypercalcemia, and about a quarter of patients will have skin findings. You can get these red-brown papules and plaques. Here are some different presentations, and as you can see, they look different. And so here you almost see these linear you see papules in a linear array and some plaques as well. And these are almost erythematous to brown. And you see here a flesh-colored lesion. And then here, you see all these papules, even involving the eyelid surface and the nose. You want to check for enlarged lacrimal glands by averting the upper eyelid. And another trick you can do is use dioscopy, which is when you press a microscope slide onto a skin lesion, and it compresses the skin lesion, and it'll show an apple jelly color. And so here's a symptom I kind of showed you, the shortness of breath, cough, rash. You can get arthralgias, anorexia, and hilar lymphadenopathy. Neurosarcoid, like I said, could affect any organ. You can see cranial nerve palsy and hearing loss and have blurred vision. And as you can see, can affect other areas. So some sarcoid variants, Lofgren syndrome, which we talked about with erythema nodosum, and then lupus pernio. This is not lupus. I know it's a very confusing name. We like to do that in dermatology, have some confusing names. These are violaceous papules and plaques on the nose, ears, and cheeks. And 75% of patients with lupus pernio have chronic sarcoidosis of the lungs. And so if you see that, then you know there's likely pulmonary involvement. And then about half the patients can have upper respiratory involvement. Duryea-Rusi is another variant, and so is Hereford syndrome. Hereford syndrome is you get fever, uveitis, parotid gland enlargement, and cranial nerve palsies, and the facial nerve is often affected. Okay, so here we see these atrophic scar depigmented plaques. This is lupus. There are several variants of lupus, and you can get various different skin findings. 4 of the former criteria of systemic lupus are skin findings or visible findings, such as photosensitivity, discoid rash, malar rash, and oral ulcers. Malar is kind of your classic butterfly rash, covering this distribution here over the nose and medial cheeks, and it occurs after sun exposure. It's made worse by the sun, and it can precede systemic symptoms by weeks. And discoid is your scarred, really obvious skin lesions that can become atrophic and hypodepigmented, and you see kind of this like stuck on scale. And as you can see, it's quite obvious. Here are some oral findings that you can see. Another kind of classic butterfly. You can start to see these telangiectasias also develop in lupus. And you see the sparing here because this little crease doesn't tend to get a lot of sun. It's more the outside of the cheeks. And here you can see some more mucosal involvement of the lips. Discoid lupus can occur without systemic lupus, meaning you can just get discoid lupus or skin lupus without systemic lupus. If systemic lupus doesn't occur within the first few years of the diagnosis, there's a low probability of it developing. However, discoid lupus can be very disfiguring to the skin, as you can see here. Bullous lupus is, you want to think blisters. It's a variant of systemic lupus. You can also develop purpura due to vasculitis or thrombocytopenia. This case is likely a vasculitis if I had to guess. Lupus profundus is inflammation of fat appendiculitis that can be seen. Fortunately, it's not common, but you can see that in systemic lupus. And then subacute cutaneous lupus is annular to psoriasiform lesions in a photodistribution, which you can see in this bottom right image. You can also get telangiectasias around the nail fold, which you can see in the left image. You know, I'm just realizing, I'm so sorry, you guys. I thought my little laser pointer was on. I hope you guys can see me moving my mouse now. Telangiectasias around the nail folds here. And then here you see livido reticularis, which is that persistent modeling of the blood vessels in the skin. And this can give you a clue of possible lupus or cryoglobulins, although it can be associated with other collagen disorders, autoimmune disorders, or medications even. So, okay, well, way to go. You guys got a little bit closer to being a skin expert. There's a lot of other systemic diseases out there. So I definitely encourage you to utilize the VisualDx app, because you'll see a wide variety of different images from, you know, imaging of a systemic disease in terms of, you know, chest x-rays, radiographs, CT scans, but you'll also see the skin manifestations as well. So right now we'll take a break to go through some questions, and then we'll begin our Kahoot quiz. So let's see. I'm going to stop sharing my screen for a second. Okay, so let's see what our questions are. Okay, how can you get access to VisualDx? Kim, I'll let you handle that one. Maybe we can talk about that after the presentation. And then we do have an actual academic question: how to differentiate keratoderma blennoragicum versus psoriasis morphologically. I would say distribution and onset are going to be really important. So psoriasis tends to like classic areas. You know, skin rashes never read a textbook. So they're not held to exact rules, but the classic areas for psoriasis, can occur on behind the ears, bottom of the scalp, elbows, lower back in the sacral area, and then extensor knees. It also can affect, the nails. It can affect the palms and soles, but you tend to have more classic findings with psoriasis. Curated tends to be, you think of just, the soles. You can occur technically on the hands as well, but it's very thick, and at times it can even be more eroded. So it's going to be hard to differentiate, but I think your onset, location, and then history are really going to give you a clue. I will say that I think for most of us, when we spot psoriasis, it's a lot easier to spot cradoderma blennoragicum because you have that association with other symptoms. You're probably not even thinking about necessarily psoriasis. That's a good question. Okay, let's see. Is calciphylaxis an emergency? If we see this outpatient, should we send to inpatient? I would say you're likely not going to see this as an outpatient. I've only seen this as in the hospital. These patients tend to be sick. And so you're probably, if you do see them, there's probably gonna be other things going on to where they need to be in the hospital anyway. And they're gonna be in so much pain that pain management is gonna be really important. And yes, you're probably gonna wanna send them. They're probably not doing well at all, and they'll need to be admitted. Okay. Oh, thank you, Shivani. This session is amazing. I appreciate that. Is it possible to get the presentation for a reference? Yes, we'll be sending it out. And then, yes, somebody said, thank you for the information, Kim. Okay, and let me check the chat. I think that's all. So we can go through our Kahoot quiz.
Wonderful. Just give me a second to get that loaded up for everyone. Maybe keep checking the Q&A in case some people might have that while I get that while I get the Kahoot quiz ready.
Okay, yes. Oh, hello, doctor. My name is Tanya from Indonesia. I'd like to ask of a patient who came in with white nail on the distal edge of nail plate, came in here, even the nail have cuts. What possible? That's a good question, Priscilla. That is a very difficult question to ask because we would really, well, we can't give any medical advice via webinar, but white nails with I'm assuming you mean transverse grooves or indentations. That could be a wide differential. And so, it would really, you would need more history, and, a dermatologist would really need to evaluate it. So a lot of possible diagnoses, and I think that might be kind of beyond the scope of our talk. Okay, the next question from Stephanie is, for the diabetes skin manifestations, can these all be prevented with good glycemic control? I would like to say that glycemic control can improve it, but technically necrobiosis lipoidica diabeticorum can even occur, even if somebody has good sugar levels. Microvascular changes, although they can be slowed and mitigated by glycemic control, you can still see that can occur. And if there's still insulin resistance, even despite your good glycemic control, you can still see some of those findings. So, people with insulin resistance don't always have overt sugar level changes, like their hemoglobin A1C might not be outrageous yet. So, okay. But yes, I always say aim for good glycemic control. That should be your goal no matter what. And hopefully you would see fewer skin findings, but it's still possible that you can see some of the skin findings. Okay, let's see.
I think we might have covered them all. If we want to move on to the Kahoot, you continue to ask questions in the Q&A while we do this, and maybe we could just if we have a little more time, we can answer them at the end. So let me share my screen. Hopefully all can see my screen. So what you're going to want to do is go to the Kahoot app and type in that PIN that you'll see, 6621278. You'll want to have it on two screens. So you'll want to be using your phone plus seeing it on like a desktop or a laptop monitor, because you're going to see the image on your screen, and then you're going to answer the question on your phone, like A, B, C, or D. Azeen, we talked a lot about VisualDx. I know you've been a longtime user of VisualDx. We recently made some really great improvements highlighting a lot of our skin of color features. We've been pretty systematic in our 20 years of curating the best medical image library, and that includes images on all skin types. I don't know if, Azeen, you want to just talk a little bit about that while we wait for people to join the
I would like to talk about that. And I think, we have to be cautious because skin manifestations can look different in skin color types, meaning different people have different skin tones. As we saw in the images in this PowerPoint, the rashes can look completely different. And so you're very fortunate to be able to see the skin during your exam. And I think it's kind of like nature's way of giving us clues as to what's going on with the patient. And so no matter what the skin type is of the patient, you want to be aware of what these skin findings are so you can better diagnose the patient. And so I would definitely encourage you, especially if you're looking up a diagnosis in VisualDx, look at the different skin types and get really familiar with it. We saw how urticaria can look different in different skin types. We saw that sarcoid can look different. Sometimes we tend to associate even diseases with only one race. So for example, a lot of people think of sarcoid and they only think of, it affecting African-American patients, but you have to be aware Caucasian patients can get it too, and it's actually misdiagnosed in them. And then vice versa, you have, associations like rosacea only occurring in Caucasian patients, but it actually occurs in all races. And so you can miss it in your African-American patients that way. So definitely that's a great feature. VisualDx has been shown to have more skin of color images than even the dermatology textbooks.
Thank you so much, Azeen. I think we'll get started. I appreciate everyone signing up. And right after this, Azeen will kind of go over the answers and describe why it was this versus that. So that'll be important. And then also I just want to mention, as we're winding down this presentation today, there will be a survey at the end, and please fill that out because we're always looking for other topics to hold in the future. So you're going to see an image and you're going to have 20 seconds to answer it. Okay. And talk about what you think it is. Here we go. Well, that was fun, Azeen. Thank you so much. And let's see who the big winner is. It's Woot. And so Woot will be in contact with you for your prize. Again, thank you so much. I'm going to stop sharing my screen. But, thanks everyone for participating. And Azeen, I'll let you take it away to kind of quickly explain why things were one answer versus the other.
Yes, you guys did a great job. I'm very impressed. Everyone answered the questions as a group collectively so well. Okay, so we'll kind of run through this.
I do see you on presenter mode, Azeen.
Okay. Let's see. Thank you, Kim. How about now?
Perfect.
Okay. So we actually use this image in the presentation or something very similar. And so you can see these flesh colored, and some of them are kind of more brown, smooth papules and nodules on the nasal alar rim. And this one, I just feel like if we did dioscopy, put that glass slide on it, would look like apple jelly, right? It just seems like it would. And you can see here that it's widespread. This is sarcoid. And one thing I want to mention, you want to be cautious that this isn't misdiagnosis one of your inflammatory skin conditions like rosacea or acne, because that can happen. This is systemic lupus. We see scarring here at this point. And so you do see some telangiectasias, little broken red vessels, but scarring and atrophy are the most prominent features here. And the scars, you can kind of tell because it's a different skin texture. And then you also see that the skin pigmentation is altered in the scarring. And so you see hypopigmentation there. This one's tricky. It's keratoderma blennorrhagica, but instead of it being the classic really thick skin, this is almost eroded. It's, you do see scale here. Let me put my little laser pointer on. You do see scale here at the rim, but you see some areas are almost kind of weepy looking. This is not the same distribution as tinea pedis, which likes the moist areas and fold. Although tinea pedis does like this region here, the fact that this is all spared, but just the distal toe pads are affected and the pressure points kind of shows you this tinea pedis. All right, so we didn't directly talk about perniosis or chilblains, but we indirectly did. And so I thought this was a fair question because we said COVID toes is chilblains like or perniosis like. And so you can see here we have, this is affecting the distal toes, and then you see that there are erythematous to biolaceous papules, and you see here these almost deep-seated flesh-colored papules that can result from some fluid trapping in the skin. But these look very edematous and almost, this one looks like it's almost a vesicle, like it has clear fluid that's accumulating. And this one is eroded. The top layer of skin has sloughed off. This is very classic for calciphylaxis, and it's so notable in, on physical exam. You see these necrotic retiform plaques. Remember retiform means kind of like a broken net. And so that's kind of what you see here. When this has an ulceration forming, this patient is likely very sick. Like I said, I don't think this is somebody who would see you outpatient. You're likely going to get this inpatient because this patient is likely already admitted because they're sick. Measles, this one was kind of tough because we don't see measles often. Fortunately, we have a great vaccination program historically, and measles has been globally eradicated, but now with certain communities not vaccinating, and also we've had cases kind of pop up in certain areas. I do think we need to be aware of it. And so you see these erythematous macules on the cheek. The fact that somebody has oxygen in an image is always a clue that if they're ill, right? This is somebody who's already really ill. So that kind of gives you a clue anytime you're taking a test or anything, look for other clues in the image. But this is widespread, and they have periorbital pallor. This one's hard. So, I put purpura or bruises because I think that would be something that somebody might include in their differential. And a lot of times patients with erythema nodosum will even say it almost feels like a tender bruise. So, but you can see in the darker Fitzpatrick type, it's very subtle. So you don't see that bright redness. It almost looks like a hyperpigmentation or almost violaceous. In this picture, it looks more hyperpigmented. Here, it's more obvious that it's violaceous. Violaceous meaning kind of more of a purple color. And so, I put cupping and factitial as a diagnosis. I do want to caution that you should never assume anything is factitial. That's a diagnosis of exclusion. And so, in a situation like this, sometimes we have a bias where we can, somebody tells us, oh, I think it's factitial, or, this patient might have a history of something that makes you think factitial, but you want to rule everything else out first. Okay, this one is also a classic for your bullseye appearance of a large erythematous patch. This is different from other skin lesions that have a cockade pattern or kind of a, 3 zones. This is just classic bullseye. Urticaria is not likely in this because urticaria rarely results with a single lesion. And so this is a single lesion here. And you can see your 2 zones of color. Now this is urticaria. So although this is annular, we look back and we think, oh, well, this isn't technically annular because you don't have central clearing. But here, this is annular. I could see why you might get confused between urticaria and Lyme disease, but this is different. You can see that this has that rim of pallor around it. So you do have a red annular plaque or patch. You would have to palpate it to tell if it's raised or not. But you have that pallor around it. You have multiple lesions too, and some of these are papules. You can tell that they're raised. So these would likely be wheals. When you feel it, you should be able to feel that there is kind of swelling in that that skin, induration in that skin. And lastly, this is a tick. This is the Ixodes tick, which is responsible for Lyme disease. So that is the last slide I have. And I will pass over the reins to Kim.
Well, Azeen, thank you so much. I so appreciate you taking the time, and I think it was a wonderful presentation, very informative. I kindly ask you to take the survey that'll pop up as you're exiting this webinar, and give us suggestions on additional webinars, because I think we're going to be continuing this into 2021. I also put in the chat that we have a lot of other exciting events coming up in the coming days, weeks, and months, and you can check those out at visualdx.com/events. So thanks again. I hope everyone has a lovely Thursday evening.
Thank you.
And we'll see you all again soon. Thanks so much.
Thanks, guys. Bye.